Welcome, everyone, to today's monthly seminar on spirituality and health. And today, I am particularly delighted to introduce John Peteet, Dr. John Peteet. John received his MD degree at Columbia University. He completed his medical internship at UNC in Chapel Hill, although we won't say much more about that. But in any case, he did his residency at the Massachusetts Mental Health Center at Harvard, and also a fellowship at the Peter Bent Brigham Hospital at Harvard. He's for 45 years been a psychiatrist at the Brigham and Women's Hospital and the Dana-Farber Cancer Institute, where he is an associate professor of psychiatry at Harvard Medical School. He has published extensively in the areas of psychosocial oncology, addiction, and the clinical interface between spirituality/religion and psychiatry. He is a distinguished life fellow of the American Psychiatric Association. Dr. Peteet received his APA's Oskar Award and is past chair of the APA Caucus on Religion, Spirituality, and Psychiatry. So who better to talk about the virtues in psychiatric practice? John, take it away.
Thanks, Harold, for that kind introduction and for this chance to think together about the implications of the virtues for mental health practice. Let me see if I can share my screen. Is that working?
Yes, that's working.
Okay. So just to remind everyone of ethical theory being divided into consequentialism, which focuses on the consequences of actions, deontology, which focuses on duties, and virtue ethics, which focuses on character. Virtue ethics has been getting more attention in the last few decades. These are publications by Oxford Press on various virtues. And there are various definitions, but I like this one because it's simple and clear from Jennifer Hurt at Yale. Virtues are stable dispositions that enable an agent to respond or act well. We're all familiar with Aristotle's cardinal virtues of practical wisdom, self-control, courage, and justice. But the faith traditions all have virtues that they encourage and constitute resources for, I would like to argue. We can hear from the Bhagavad Gita this quote about peacefulness, self-control, purity, tolerance, etc. The Christian scriptures, the fruit of the Spirit is love, joy, peace, patience, kindness, goodness, etc. Quran, kindness. The Buddhist emphasis on self-control, restraint, and the Hebrew tradition, a lot about the virtues in Proverbs. What about psychiatry? In the moral treatment period, which began in Europe, as you know, and came to the US, there was an emphasis not only in more humane treatment of the mentally ill in asylums, but on discipline that encouraged the virtues. And Benjamin Rush, who is known as the father of American psychiatry, in his institute in Pennsylvania, developed this moral and physical thermometer, where he outlined virtues as compared with vices, and the diseases you can see here that were correlated with the vices. All part of the moral treatment period in US psychiatry. But after that moral treatment period, there was a long period in which there's been a neglect of the virtues for a number of historical reasons. We can hear Freud talking about this being an unrealistic thing. The commandment, love thy neighbor as thyself, was impossible to fulfill. the argument that they're subjective and unscientific. The more biologically oriented colleagues of ours talk about psychotherapy as just another way of creating synaptic potentials. And the concern that it's moralistic to think in these terms. Foucault is probably one of the most potent spokesman for this point of view in Madness and Civilization, where he argued that the quote moral asylum is not a free realm of observation, diagnosis, and therapeutics. It's a juridical space where one is accused, judged, and condemned. But then around the turn of the last century, the end of the 20th century, we had resurgence of interest in the virtues coming from positive psychology. Martin Seligman, in his 1998 address to the American Psychological Association, said the main purpose of positive psychology is to measure, understand, and then build the human strengths and civic virtues. And any of you who are familiar with positive psychology know the emphasis on empirical study of character strengths and virtues. Philip Jest, the former American Psychiatric Association president, has also developed the notion of positive psychiatry and published about it. Tyler Vanderweel at the Harvard Center for Human Flourishing has also advanced the empirical study of human flourishing, which, as you can see in this paper from the Academy of I think it's the Proceedings of the National Academy of Sciences, sorry, includes virtues, character strengths, and virtues as core elements of human flourishing. And I've written about a fourth wave of psychotherapies that move beyond recovery, remission of symptoms, to growth and well-being, including these forms of fourth wave psychotherapy: existential, dignity promoting, gratitude promoting, spiritually informed psychotherapy, etc. And there are three philosophers who have been helpful to me in thinking about this interface between virtues and mental health practice. The first is Eric Matthews, who wrote some time back that medical treatment in the form of drugs or even surgery may help to alleviate the effects of such a condition by making it easier for the person to fit with conventional society. But the appropriate treatment for the condition itself involves a certain vision of what a satisfactory human ought to be like. A way of interpreting what is, quote, wrong with clients is deviation from that moral vision, and way of treating clients aimed at showing them ways of achieving that moral vision in their own lives. It's highlighting the moral dimension of the values that we inevitably operate with in treatment. And then Duff Waring, a philosopher at Toronto, wrote this book, The Healing Virtues, published by Oxford, in which he describes virtues as therapeutic goals that stress the desirable and stable traits of character that healthy persons have, and that patients who want to restore lost selves ought to strive for. And he argues that therapists have a role in cultivating virtues such as self-love, self-respect, empathic concern, respect for others, since attaining these at sufficiently stable states amounts to positive mental health. And he uses the examples of the demoralized woman who discovers herself through identity-conferring efforts, and the example of the angry man who recognizes the origins of his, quote, simmering antipathy and begins to take responsibility for changing it, which is when he experienced the healing virtues of dialogue and empathy and self-control. Another philosopher who's been helpful to me in this is Gerrit Klaas in the Netherlands, who's written about self-relational, contextual, and normative perspectives in the work that we do. And besides being a philosopher, he's also a residency training director in psychiatry program there. This book, some of you may be familiar with, by Jennifer Radin, a philosopher, and John Sadler, a psychiatrist at UT Southwestern, devotes chapters to the virtues that are important for a psychiatrist: empathy and compassion, warmth, self-knowledge, integrity, etc. And it's quite a nice book with clinical examples of how these virtues are key to psychiatrists doing a good job. But not so much is written about the role of virtues in treatment. And I'd like to think together today a little bit about that in terms of first, diagnostic assessment, second, treatment planning, third, implementation of treatment, which I'm suggesting involves thinking with the patient's moral compass, practicing virtues, and engaging sustaining resources. So in terms of diagnostic assessment and needed virtues, we can think, of course, about personality disorders as representing a lack of compassion in the case of antisocial personalities, humility in the case of narcissistic personalities. But also when we get to depression and think about the guilt, inhibition, and impaired self-love that's often present, it's natural to think about forgiveness, love, and compassion as needed virtues in many of those cases. With anxiety, with its fear and distractibility, we can think about the virtues of equanimity, courage or defiance, and phronesis or practical wisdom. And in substance use disorders, with their impulsivity, irresponsibility, guilt over damage done, we can think about the relevance of the virtues of accountability, gratitude, and self-forgiveness. And when it comes to dealing with moral dilemmas, practical wisdom in prioritizing virtues. So when it comes to treatment planning, I think we're often asking how we can help patients identify their hopes for living well, what matters most to them. You can see this in ACT. This is especially relevant in cases of trauma, demoralization. We can think about how to help the depressed patient see the possibility of hope or self-forgiveness. Does the therapist need to lend her own hope in those cases? When we come to the anxious patient, can we help them believe that they can become less distressed? Do they need to learn to lean on the therapist's equanimity? And in helping the substance using patients see that a sober life is worth living, can they benefit from a group promoting honesty, accountability, and forgiveness? And then in terms of implementing a treatment plan, recognizing the patient's character strengths, modeling virtues such as trustworthiness, empathy, warmth, self-knowledge, a la Radin and Sadler, and then identifying desired virtues needed for the challenges that the patient is facing. And some of this you can see in the strength-centered therapy literature, envisioning what are the strengths you would like to develop, empowering who can encourage you to become more prudent or courageous or whatever. And then evolving, what strengths can you rely on if this problem rises again? And then practicing virtues. This quote is attributed to Aristotle. We don't know if it actually came from him, but we are what we repeatedly do. Excellence then is not an act, but a habit. Through insight gained from dynamic or schema-based approaches, we can help patients better anticipate and master recurring challenges. Through CBT, DBT, and ACT, we can help foster equanimity, practical wisdom, and courage as a matter of habit. And through these fourth wave therapies, we can foster virtues such as gratitude, forgiveness, and compassion. And then there's the aspect of engaging sustaining resources by looking to inspiring exemplars for patients. mentoring and accountability, enhancing relationships in their lives, spiritual practices, and communities of faith. I'm going to present a few case examples here that I hope illustrate some of these notions about how virtues can play a role in treatment. 50-year-old woman presented after recurrence of breast cancer with insomnia and emotional distress. Interviewer reviewed with her a history of both past resilience and vulnerability to anxiety and despair at times of stress. They identified equanimity and hope as desired virtues going forward and discussed ways she could find resources outside of the treatment. These included inspiring mentors, familial and other sources of support for realistic hope, and her religious community with its beliefs in God's care and practices of prayer and community. It's not an uncommon kind of consult that I see in my work at Dana-Farber. Second example, a 37-year-old single administrator presented with depression and anxiety of several months, concerned that she might never find a partner. Her relationships had followed a pattern of somewhat obsessively pursuing men who showed beginning interest in her and then withdrawing to protect herself from anticipated loss. She'd been a practicing Catholic, but she was now struggling with cynicism and doubt about whether God cared about her plight. Exploration traced persisting insecurity to experiences of volatility and harsh criticism from an alcoholic mother. Treatment helped her to see the impact of her childhood experience and aim for virtues of courage and realistic self-appraisal, drawing on both her supportive father and attentive therapist as models for this. And going further to identify what would be involved in her flourishing, her therapist noted her loss of purpose in her work life and helped her to explore sources of self-transcendence as a virtue worth recovering. She used this encouragement to engage more fully with colleagues at her mission-based work setting, as well as in her church. Third example, a divorced woman in her 70s described being depressed and self-denigrating for much of her life. She'd grown up with a critical mother and later accommodated the unreasonable demands of an alcoholic husband. Around the time of her divorce, she entered a several-year psychotherapy with a psychologist whose consistent interest in her and her experience allowed her to regard herself differently as worthwhile and capable. And in her later years, she consolidated this as an enduring stance, giving to her children and others from a sense of generosity rather than obligation. She said this about her therapist: "He gave me what I came to be able to give myself." So coming back to the way that faith traditions can espouse preferred virtues, we can think about often the notion of bettering the world and critical thinking as highlighted by the Jewish tradition, Christians emphasizing unconditional love and forgiveness, Muslims emphasizing reverence and submission to the will of God, Buddhists, compassion, renunciation of craving, Hindus, dharma referring to duties and karma, cause and effect, and secularists emphasizing often reason and individual autonomy. I'm going to shamelessly talk a little bit about this book that I edited last year that highlights some of the virtues that are described in these chapters. First of all, virtues of self-control, accountability to others, fulfilling relational responsibilities, facilitates flourishing mental health, and conversely, difficulties in appropriately responding to others with answerability or impairments in self-regulation pose challenges for flourishing. Humility, being grounded in an accurate perspective, encourages flexibility in our self-assessment. Dr. Brenner from UT Southwestern has given grand rounds here and elsewhere on the virtue of humility in psychiatry. Equanimity, mentioned before as a sort of paradigmatic Buddhist virtue, consists of an accepting and unattached disposition, which can facilitate a more rapid return to a baseline. We're familiar with mindfulness and meditation as well-established methods of cultivating equanimity. And there's now neuroscience around both of these. Virtues of benevolence, forgiveness. There's a large literature now about forgiveness, which is considered a virtue by most people, as promoting better relationships, better physical and mental health, often better spirituality. Compassion, a virtue fundamental to medicine, as well as Buddhism, combines courageous engagement with suffering, seeking of wisdom for its relief and prevention. As such, it has value not only as an antidote for suffering and antisocial behavior, but also in support of human flourishing. Love is central to human flourishing, helping patients to love more effectively and become an important focus of the treatment. The therapist's love for the patient is often central to the establishment of a therapeutic alliance. Virtues of intelligence. Defiance is sometimes a virtue for people with mental illnesses. Sometimes defiant behavior is even a step toward flourishing. And there are times when clinicians are rightfully defiant against accepted norms. Phronesis or practical wisdom amounts to sound judgment in identifying specific goods to be pursued. And then the virtues of positivity, gratitude, again, a large literature about gratitude and the mental health benefits it confers. Self-transcendence, a virtue that Robert Cloninger has studied and described, the process by which a person becomes aware of their participation in something greater. Hope, understood as a virtue rather than a belief or an emotion, lives between the twin vices of despair and presumption, represents the capacity to rest in a not yet present, difficult to attain good future that will be brought about by an agent outside the self. This is a formulation by Warren Kinghorn at Duke. And I'll just end with a few caveats, which Tyler Vanderweel has articulated in the final chapter in the book. And the first is that blaming the victim or moralism that Foucault described can be a risk when you're thinking about encouraging virtues in therapy. Not all mental health failings are due to a lack of virtue. Living in accord with virtues that serve others can lead to hardship. And then the fact also that hardship sometimes plays a role in the development of virtues. And finally, I just want to suggest that rather than being a kind of icing on the cake of clinical work that we do, the virtues are actually intrinsic to the cake itself. And my thoughts about this are just a way to encourage us to think in those terms. So I'm going to stop there. There's a bibliography that anyone can see who gets the slides, and looking forward to some feedback conversation about this whole idea.
Excellent, John. Okay, so let's ask some questions. Just unmute yourself and let's dig into the wisdom that John brings to us all here. Let's take advantage of that. So go ahead. Reverend George, I believe, is unmuted.
Yes, John, I'm retired as a psychiatric social worker and have been very active and involved in the 12-step movement. I was wondering of your opinion of the 12-step movement with regards to the virtues that you just outlined.
Yeah, I think the virtues of accountability, of openness, of courage, of humility, and probably a number of others are represented in the 12 steps. I think that's a great example of the way that people can access the virtues as part of their mental health recovery. Even if they're not thinking of themselves as religious, they can access the spirituality of the 12-step program and I think grow in virtues as they practice the steps.
Thank you.
Hi, John, Harold.
Hello, Alexander. Good to see you.
Good to see you. John, first of all, thank you very much. Congratulations for your wonderful talk. I'd like to hear more from you. First, how do you answer that criticisms about moralisms, about imposing values, or that kind of criticism on this kind of work on virtues in psychiatry? And the second point, I would like if you could share more about your clinical experience in promoting virtues and awakening virtues in patients. Thank you.
Again, the philosophers who think so clearly about these issues have been helpful to me in describing both how values are intrinsic to the way we do our clinical work, when we have some vision of how we hope the patient is going to be able to be, and that's intrinsically value laden, and it comes from where we are in terms of our worldviews too. And then in terms of how it's implemented practically, I really like the way Duff Waring and Parrott Floss describe that in psychiatric practice. They think of the virtues as self-regarding as well as other-regarding. And I think that is sometimes a little bit easier for clinicians to think in terms of the ways that patients need to learn to be better to themselves, take better care of themselves. There are virtues involved in that as well. In terms of my clinical experience, I think the examples that I gave are ones that stood out to me from patients that I've seen. I find myself focusing when I see a patient on what is it that is getting them into trouble about the way they're operating in the world, and what's needed in the way of better ways to do that. And then I might not name the virtues to them, but I'm usually thinking in terms of what's going to be a healthier way for them to learn to live, to practice, to not just think about the world, but to actually be as a person in the world. And then who are the people in their lives who could help them with that? Not just myself as a therapist as a model, although I hope to do that if I'm doing therapy with somebody over time. But who else can I talk with them about in their life that they look to for help with the way they want to be?
Dorothy, I think you're next.
Okay. I was wondering, what do you think about integrating the expressive therapies and how that might, folks might take charge and incorporate virtues? I'm probably not too clear about that. I'm just interested in seeing how that might impact.
Can you say a little more about expressive therapies that you have in mind?
Okay. A lot of times, I was just talking with someone quite a while ago about a client I had who was wanting to commit suicide. And she came in one day and she said, "Oh, I feel like I have a lump on my shoulder. And last time that happened, I tried to commit suicide. And I had been seeing this person for a long time, and I didn't know that. And I said, well, let's do a certain activity." And I sat down with her, and I did this activity with drawing. with 3 pieces of paper, and you know, did a little bit of trance work and had her draw without thinking 3 pictures. And I also participated because I really feel that was another way of listening. And what happened was, the first picture was a mess, was very, very dark. The second picture was of her family, and the third picture was all these flowers. And she looked at them, she spread them across her the desk there and looked at them, and she started to cry. And she said, well, I have these flowers inside of me. I have heaven inside of me. And so really the therapy began. And, and over the years, I've been wanting to be able to figure out a way of having people go deeper and to take charge of themselves. And usually that kind of a self-empowerment, they start listening to other people and change.
Yeah. I guess the 2 things that come to my mind are the virtues of courage and transcendence. I think the arts, nature, beauty can have more of a transformative effect in patients' lives than we often give them credit for. And I don't know that much about expressive therapies directly, but I'm assuming that part of what you're doing is helping patients access those self-transcending resources, and fostering their connection with the larger reality in that way.
Mm-hmm. So there is a connection with building of virtues.
Yeah, I could hear
through experience.
Yeah.
Yeah. Thank you. Wonderful talk.
Glenn?
Thank you, John, for a beautiful presentation. So the Buddhists do a great job of articulating self-compassion. I'm wondering, for people who are Christian, if you've come across any good references for teaching that from a biblical perspective.
It's a good question. I probably have to think a little bit about that. I mean, we're to love others as we love ourselves. That means we're supposed to love ourselves too.
Yeah.
We're supposed to think about ourselves as worthy in the way that God thinks about us. Have compassion for one another the way God has had compassion for us. I'm sure there's scriptures that speak to those things. Maybe other folks on the call who have more theological sophistication than I do can speak to that.
Okay, thank you.
Donald, go ahead.
Thank you. I wanted to jump in on that whole aspect of self-compassion. I've been reading Richard Rohr's book, The Universal Christ, and one of the things that he talks about in it that I discovered on my own is the interchange between Thomas and Jesus and the resurrected Christ. And you have Thomas touching Jesus and touching his wounds. And it really is an aspect of compassion when you can view the wounded God, that we have this idea we carry this idea in Christianity that perfection is without blemish or without whatever. And when you can image God as being wounded, it has a sense of compassion, and it has a sense of being able to draw people into the fact that their woundedness isn't a flaw, but it's part of being fully human. And I found that passage and that illustration to be very, very helpful, because oftentimes we focus on the doubting Thomas rather than the resurrected wounded one who still bears those wounds, which I think is a really compassionate way to show people that it's wonderful to be human, and it's also wounding to be human at the same time.
Very good.
I just want to add a comment to the question on compassion. I'm sure Dr. Peteet probably knows about this book, How Doctors Care, The Science of Compassionate and Balanced Caring in Medicine by Dominic Vachon. I think it's from Notre Dame. I mean, it's a beautiful book. He's a Christian, so has the Christian worldview and philosophy embedded, but really describes compassion. I mean, he goes into the difference between sympathy, empathy, and compassion. You know, sympathy is to be sorry for somebody. Empathy is to be sorry as well, but feel like doing something. And compassion is when you go further to do something about it. It's a very beautiful written book, and in case, just to help the question that was posed earlier, the importance of, like all of us know here, compassion means to suffer with somebody, from Latin compassio. But it's something that certainly from the Christian perspective, that all of us, in all aspects of medicine, and more so in psychiatry, will want to practice. But this is one of the best written books I've ever seen on treating that subject. He has a couple of podcasts that he's given just for those interested. Thank you.
Thank you, Manny. What was the name of that book?
Yeah, what's the name?
How Doctors Care, The Science of Compassionate and Balanced Caring in Medicine. And Dominic, the last name is spelled Vachon.
Thank you.
Thanks. Yeah, that's great.
Manny, could you type that into the chat?
I will.
Great, thank you. George, did you have something to say?
Yes, I just wanted to respond to Glenn's request about the book recommendation. This is entitled The 5 Pillars of the Spiritual Life by Robert Spitzer, a Jesuit priest.
George, could you put that in the chat too? Would you mind doing that?
I would be happy to.
Okay, great. Who's next? Yes, Russell, go ahead.
Yeah, hello, Dr. Peteet. Thanks for a wonderful presentation. And I'm not exactly sure how to articulate this question, so I'm going to think it out loud with you. But I'm wondering about, for lack of a better way to articulate it, virtues that seem to arise spontaneously as gift or almost infused or from beyond, and virtues that we identify with some intentionality. I'd like to be more courageous, or I'd like to be more grateful. And I'm wondering about your clinical experience with catching people in the act of embodying virtues versus the setting of intention or the attempting to. Does that question land or make some sense to you?
Yeah, that's interesting. I think I often find myself admiring a character strength of a patient and thinking about a way to build on it, help them take it further, make better use of it, help them understand what it's about so that they can see what's getting in the way of, fully developing it. That might be my first pass answer at that. Because usually when they're coming to me, they're feeling a need for some help with going further, getting less stuck, or and so the question is what's getting in the way, and are there aspects of their character that are getting in their way that we can think more clearly about. I want to think about what their strengths are as well as their vulnerabilities, and sometimes they're opposite sides of the same coin, right? Someone who's very assertive might have an overly strong need for control and not be able to delegate. We can think, you can think a lot of examples of that.
Yeah, like what's the fine line between generosity and masochism? Or there's a bunch of those, right? Where it's fuzzy in between. Yeah. Thank you for that response. Appreciate it.
Aristotle talked about the virtues of the golden mean between those kinds of extremes. I don't think that's the best way to think about all the virtues as on a spectrum, but clinically, I think it can be a useful way to think with patients about their strengths and their vulnerabilities along a spectrum, and the need for balance.
John, can you say a little bit more about the idea of moralism, therapists imposing their moral values on patients? I know that's a criticism that actually Alexander brought up, and that's a real challenge. Are there universal values and morals? Are there universal? Can we say that? I know there's criticism against that too. What are some of your thoughts on that, John?
Yeah. Well, I use the term syncing with the patient's moral compass to think clinically about how we're usually trying to connect with what their values are and find common ground so we can build from there on the next steps. The ACT, acceptance and commitment therapy, focuses on what the patient's goals are and how they're going to enact them. So I think that's usually the place we start clinically. If we disagree with the patient about where they need to be going, we don't think that Ativan is the best way to deal with this, or we think they need to take some other need of someone else in their life into more account. I think probably transparency is one of the better ways to handle that. That we can raise our concerns and say this is a concern that we have, and be upfront about why we have that concern, what's behind it, where we're coming from, and the patient can make a decision about whether they want to buy into our thinking about it or take issue with it. There's no complete protection because there's a power differential, and then inevitably we're influencing patients with our values. I think the more transparent we can be, and the more we can have sort of have informed consent when there are differences, the better. I think sometimes patients come looking for a therapist who's going to share their worldview or their values. You know, or a couple might not want to go see a secular therapist who doesn't respect their religious commitment to marriage, and you know, wouldn't want to see them moving them in the direction of a divorce. Certainly encountered that kind of question. And sometimes, you know, it makes sense to be explicit up front about what one's values are when it comes to issues like that that are going to be central to the treatment.
Yeah, that's good. That's good. It sounds like you're very patient-centered and meeting the patient where they are, and then, you know, kind of Socratically leading them to where they may need to be. And that's good. That's my approach too. Who's next? Who would like to contribute to this discussion? Unmute yourself and let's hear some other thoughts and opinions on this matter of virtue.
Well, I've spoken before, so sorry to
Go ahead,
speak,
Russell.
but I'm reminded of James Griffith's work. Your presentation reminds me of I think it's in the Religion That Heals, Religion That Harms book, where he talks about, where he claims as a goal of treatment that he wants to help patients become more moral. He uses that actual phrase, and that there are therapeutic health benefits to being a morally integrated, morally guided, morally led person. And anyway, I just wonder if you have thoughts or comments about that thought, his work in general, or anything.
Yeah, I'm a great admirer of his work. And I think it's tricky to use that term moral because it is so associated with moralism in our time. But I think now with the whole attention we're giving to burnout and moral injury, that's changing a bit. People are realizing there's an importance to our moral convictions, and running up against them in ways that create dissonance is harmful to us. And so it may be that his language will become a little more acceptable if that happens. We tend to use terms like values more than moral or virtues. And so I think part of the challenge is finding language that will be acceptable to patients and colleagues, that it reflects the relevance of these moral, spiritual, value-laden, worldview supported issues in the work that we do, without being moralistic. It's not an easy challenge given the way our culture tends to think about these things.
Indeed. Robin, you have a thought?
So since people were sharing books, I thought I would share a book that we did as a faculty formation. It's called The Virtues or the Examined Life by Romano Cesario. It is a heavy read. We had a moral theologian leading our discussion of it, but I think it's very, very good if you want to just really get really well grounded in the virtues. I did put that in the chat already.
Good. Good. Thank you, Robin.
You're very welcome.
Bob Roberts is a Christian philosopher who's written very well about the virtues from a Christian perspective as well. I don't remember the name of his last book, but Robert Roberts. He was at Wheaton and Baylor.
Any
So,
other?
if you have any comment on virtue in medical education, I just wonder, we a lot of us, I'm in the medical school here in Dallas, Texas, and the importance of virtue is obvious to a number of us. But of recent, talking about virtue in medical education has not been very popular. Maybe it's coming back a bit. How do you think we can bring back the discussion of virtue to, particularly in training of our young physicians, and the importance in the practice of medicine itself?
Oh, that's a great question. The ACGME criteria for evaluating professionalism includes some of the virtues. So some of that language is coming back in, I think, as we realize the importance of professionalism. And when you hear people being extolled in their obituaries or at a funeral service, you're hearing about the virtues all the time, right? More so than necessarily someone's scientific accomplishments. But we still tend to, save them for the obituaries and not so much for before death. It's a challenge. I'd be interested in other people's thoughts.
Okay. Any thoughts on that question? John, repeat that question again.
I think it was about how we can more helpfully think about the virtues of medical education.
Yeah, in this day and age, how can we do that? Any other thoughts?
This is Robin again, and what I'm thinking is that if you really look at those physicians who have greatly contributed to society, whether it's on a local level, you're going to say, as someone else already said, the virtues underneath that. So maybe one way would be to incorporate that truth into medical education.
I think there's a big debate in the educational community generally about character education in schools. Faith-based schools tend to emphasize character as part of their educational goals more than secular schools. And obviously circles around the value differences and whether you can have character that's not inclined toward one political or one political perspective versus another.
This is Don here. One of the things, I was listening to a physician out of Surrey in Vancouver, and he was talking about burnout and then recovery post-COVID. And he said one of the things he had to learn is that he had to get rid of that individualistic hero model, where he had to be able to do everything, be everything, solve everything, and come up with a way of connecting with community, connecting with a greater whole, so that he didn't have that full sense of everything rested on his shoulders. And I think that it's that vulnerability, if you want to put it, that is very important. And many, I work in a hospital. I'm a psychotherapist and chaplain, and I would say that the physicians that show that vulnerability, that can cry with a patient, that express their humanity, have a tremendous influence not only on their patient to doctor relationship, but also relationship with the team around them, because it models that humanity.
That's good, Don. That's really good.
Yeah, and we know that a lot of medical education takes place in the informal curriculum, the modeling that takes place on clinical teams. And to your point, the virtues are learned by example and by practice as part of that kind of apprenticeship. Yeah.
Yeah, you know, I think there are more universal moral and ethical values, you know, that I think most humans are going to relate to. They may, you know, they may struggle with them, and they may, you know, object to when the therapist, you know, challenges them on these issues. But I think most people know what's right and wrong. Don't you think so, John?
Yeah, I think that's part of the beauty of Tyler Vanderbilt's work on human flourishing. He's looking at across cultures at what people value, what makes their lives flourish, and there are some universals that he's identifying with an empirical basis, I think, which include these kinds of character traits, virtues, commitment to the community.
Has he written that up anywhere, John? Do you know?
Well, he's got a number of initiatives focused on different aspects of flourishing. And if you go to the website, you can see how far he is with each of those.
The Harvard website on flourishing, right?
Yeah, Harvard's program on human flourishing. And he has a newsletter too, if anyone's interested in getting on it. Yeah, email newsletter.
Well, I think there's a, thank you, John and Harold, for this great webinar. There was a time when I was working in a general hospital and was asked to do a consult on a person in the ICU who had now refused his cancer medications and wanted to relinquish treatment and see how things went. So I was called to consult on his competency for that. Did the usual consultation, got history information about his diagnosis, and did he know his treatment options and the ramifications of treatment, not treatment. And then I started to ask spiritual questions about, you know, what does it mean when you die, and what happens when you die, and are you ready to die? You know, what do you believe in an afterlife? And you know, we had some long discussions about things, you know, about forgiveness and transgressions and relationships and things that needed to be done yet. And we didn't have the same faith. He asked me to share some of the things I thought as well in the process. And it was just conversational. It wasn't, no, here's what's right or wrong, or here's what's absolute or anything like that. You know, obviously in my mind, there's things that are absolute, but as we had a discussion, just conversation, you know, he felt really good about it. The nurse overheard it and reported me to the hospital president for trying to proselytize. And whenever the president came, I said, well, let's just, you know, ask the patient what he thought. And the patient said, you know, I've had this diagnosis for almost 5 years now, and nobody from the medical community has had this conversation with me. I've wanted to have this conversation for a long time, and everybody always avoids it, pushes it off, says, well, somebody else will talk to you about it, or a chaplain will talk to you about it, or somebody. And he says, I just wanted somebody with a medical knowledge that is bigger than just sort of a theological knowledge to be able to speak to this or just have a conversation about it. And he decided to go back on medications because he wanted to prolong his life a little bit longer, to finish up some of the things and to explore some of the spiritual possibilities in the process. But, you know, I think that sometimes we're a little bit afraid, but, you know, people come to us for our expertise. They come to us for our expertise psychologically, medically, as far as therapy, but also spiritually. They're asking for our expertise in that. And I think if we communicate it in a friendly, compassionate, values-based way of respect, honor, and dignity, it's amazing how many patients that don't share our belief are very open to the respectful way that it's presented to just be food for thought and to be able to allow a collaboration and a teaming, and because they want that expertise. They want to hear, especially we've been in this space for a long time. We've seen some incredible things happen, and they want to be able to glean from that and apply some of those things that we've learned and our expertise into their space.
Yeah, I think that's a great example of how the concern for moralism can be misdirected. Tor Curlin and his colleague Hall have written a nice paper that speaks to some of those issues called Strangers versus Friends, or something like that, about it. The way to have conversations that go beyond neutrality and competence to wisdom and respect, and when it comes to those kinds of spiritual value-laden conversations with patients.
Okay, we are at the 1 o'clock hour. And so I want to thank John for, a terrific presentation and a great discussion. All of you, have contributed, enormously to this. So just thank all of you, and especially John, for taking your time this afternoon. And so we'll see you next month. God bless and stay safe.
Thanks
Merry
a
Christmas,
lot.
everybody.
Merry Christmas.